Hello everyone, my name is Claudia Prieto from King's College London, and I will be talking about overcoming technical challenges in PET-MR imaging of the heart. So simultaneous PET-MR promises a comprehensive assessment of cardiovascular disease, providing complementary and co-register anatomical, functional, metabolical, and tissue characterization information, including, for example, scar, fibrosis, and edema with MR, and inflammation, viability, and plaque characterization with PET. There is also overlapping information provided by both modalities that may help to increase confidence in the diagnosis. So promising clinical applications include arteriosclerotic plaque characterization with sodium fluoride, as well as myocardial disease assessments such as cardiac sarcoidosis, which is an inflammatory disease with patchy manifestations of inflammation and fibrosis. There are many other potential applications, including aortic calcification and amyloidosis, which can be explored with a wide range of radiotracer, as you can see here in this table. However, there are still several technical challenges for cardiac PET-MR that need to be overcome, with one of the main ones being that the heart moves due to physiological cardiac and respiratory motion. So the problem is that motion can induce mismatches between attenuation and emission data, leading to inaccurate PET quantification, as we can see in this case that could be misdiagnosed as a perfusion defect. Motion can also introduce blurring and aliasing artifacts in both PET and MR images, as we can see in the second example, where we can see images before and after motion correction for both the PET and the MR data, which again may impact the diagnosis. So although simultaneous, cardiac PET-MR acquisitions are not necessarily co-registered. PET data is acquired in 3D under free breathing. However, MR-based attenuation correction maps are acquired under breath hold. Whereas most of the MR scans are performed 2D in different orientations, as shown here, and also they are acquired under multiple breath holds. Therefore, not only PET and MR data are acquired at different motion states, and therefore motion correction is required, but also the fusion of the 3D PET and 2D MR images, which were potentially acquired at different positions, can be challenging. So a potential solution to move towards a truly simultaneous and co-registered cardiac PET-MR scan is to perform PET and MR acquisitions under the same conditions, meaning both in 3D, acquired with the same orientation, and under free breathing, enabling direct fusion and analysis of the complementary information in the co-registered dataset. So to achieve this, we required solutions to correct for motion in the simultaneously acquired PET and MR images, as well as enabling 3D multiparametric cardiac MR. And in the rest of this talk, I would like to summarize some of these methods, starting with motion correction approaches. So as we know, simultaneous PET-MR has greatly expanded the possibilities for MR-based motion compensation in PET, since motion fields can be estimated from the MR signal and used to correct both for the attenuation and emission PET data, but also the MR data. So what do we need for motion correction in cardiac PET-MR? First, we need a surrogate signal for the cardiac and the respiratory motion. So for example, this could be the ECG signal for cardiac motion, or the respiratory bellows, MR navigators, or MR self-gated signal for the respiratory motion. Then we need MR imaging data to create a motion model. And this can be achieved using pre-calibrated approaches where the MR data is acquired before or during the first minutes of the PET-MR scan to create a motion model, or simultaneous approaches where the motion is estimated from the MR images that they are acquired throughout the entire PET data acquisition. And then, of course, we need a reconstruction method that takes into account the motion information. And this can be performed, for example, in this case, for PET, using the motion fields to warp all the images to a common respiratory or cardiac position and then average these images. This is called post-reconstruction registration, or incorporating the motion fields directly into the reconstruction. So an example of pre-calibrated approach was proposed by Christoph Kolbitsch and Tobias Schefter from the PET-EW in Berlin. This method estimates respiratory motion fields and consistent respiratory resolve attenuation correction maps from the same data. This is achieved by using a 3-point Dixon acquisition with self-gated radial phase encoding trajectory. So with this approach, the central case baseline is acquired repeatedly through the scan to enable foot-head respiratory motion estimation, from where the data can be assigned into different respiratory bins and then reconstructed and registered to estimate the non-rigid motion fields. Now, from the same data that it was acquired with 3 echoes, water and fat images can be generated, enabling tissue classification, and that's enabling the generation of attenuation correction map that it can be now deformed to all the different respiratory positions to generate a dynamic attenuation correction map. So that means that now all subsequent MR scans, if they are performed with a 1D surrogate signal, can be corrected with the same motion resolve attenuation maps. This approach showed increased PET tracer uptake of about 25% and improved PET image resolution of about 20%, and showed clear improvements in line profile and sharpness with respect to the reconstruction with no motion correction and a static attenuation correction map. Now, as mentioned before, the pre-calibrated approaches generate motion models from MR data that it was acquired at the beginning of the acquisition. However, the diagnostic MR data, it still needs to be acquired afterwards. So simultaneous approaches, on the other hand, aim to acquire diagnostic PET and MR data simultaneously, correcting for motion for both of them. We have proposed in our group one of such approaches to acquire 3D respiratory motion corrected coronary MR angiography simultaneously with cardiac PET data. So this approach uses a T2 preparation and fat suppression pulses to enable visualization of the coronaries, and an image navigator, which is a low-resolution image acquired before the acquisition, to estimate and correct for foot-head and right-left bit-to-bit respiratory motion of the CMR data. We also use a Cartesian trajectory with a spiral-like order with good undersampling properties that enable in assigning data to different respiratory bins for non-rigid motion estimation. So the foot-head motion estimated from the image navigators is used as a surrogate to bin the CMR data to different respiratory bins, which extend from inspiration to end expiration, from where each bin data can be reconstructed and registered to a common position to estimate the motion fields that they are then incorporated in the reconstruction. Now, the same surrogate and the motion fields can be used to bin the PET emission data and the deformed mu maps to different respiratory positions to enable now motion-corrected PET reconstruction. So this approach was proposed by Camila Muñoz and showed improvements after motion correction for both the MR images and the PET images, as you can see here on the right panel. In a follow-up study in collaboration with the Technical University of Munich, we compared the CMR data against the gold standard invasive X-ray angiography and the FDG PET data to myocardial availability assessment against LGMR, showing very good agreement in both cases. Indeed, here in the right panel, you can see a case where without motion correction, there is the suggestion of a transmural defect. However, after motion correction, we can see that the defect was not transmural, and this is in accordance with the LGE data. So we have also observed consistent image quality with this approach across different centers, such as the Technical University of Munich, the University of Edinburgh, and the University of Maastricht. So you can see here some examples of representative images that they were acquiring these centers in different type of patients and with different radio tracers, although here I'm showing only the MR data. And I hope that you can see that we can achieve a good and consistent quality across the different places. So this approach can also be extended to dual phase acquisition in systole and diastole, which allows us to obtain ventricular function, but also to estimate cardiac motion to correct the PET data. As you can see here, the PET data shows some improvements after respiratory motion correction, and however, we can observe even further improvements when both respiratory and cardiac motion correction is performed. So the previous examples show the feasibility of the simultaneous acquisition of the motion-corrected CMR and PET data, but we were wondering if we could further improve the PET image quality. So this is indeed possible by combining the motion-corrected PET data with an MR-guided image reconstruction that further enhances the sharpness of the PET images and thereby improves the effective resolution of the PET reconstruction, as you can see here for one example of a patient, and you can see that we go from the clinical standard PET to the respiratory motion corrected PET, where we can see some improvements in the delineation of the myocardium and the papillary muscles, and we can see even further improvements now when we incorporate the motion corrected MR guided PET reconstruction. Okay, but what about the other MR contrast? So for example, looking into possible infarction and inflammation protocols as shown here, we see that we also may require the acquisition of 3D CNET, T1 and T2 maps, and LG imaging in addition to the CMR data. So the good news is that this framework can be easily extended to other contrasts, and we have shown that this can be extended to LG, CNET, T1 and T2 mapping. As you can see here, for example, for a 3D water LG image, that can be obtained by replacing the T2 preparation with an inversion recovery pulse in concert with a dual echo acquisition, as you can see on the diagram. So as shown before, and exactly in the same way, we can now obtain the non-rigid motion fields that they can also be used to correct for the PET data. In this case, we are acquiring a dual echo, so we can obtain, after a water-fat separation algorithm, water and fat images. And we could potentially use a similar approach to the dynamic attenuation correction map described before to also obtain the attenuation correction maps to correct for the PET emission data. Here you can see some examples of representative results for the 3D LG sequence for a patient with a chronic SCART, showing excellent 3D coverage with the water and the fat images. And as I mentioned before, we can then follow exactly the same idea to further extend the framework to enable 3D quantitative imaging, as is shown here for T2 mapping. In this case, we acquire now 3 interleaf acquisition with different preparation pulses, providing images with 3 different contrasts that can then be fit to generate a T2 map. Again, since the framework is based in exactly the same approach that I described before, this will produce non-rigid motion fields that can be used to correct for the PET data. And here you can see some examples, in this case acquired at 1.5 Tesla, showing 3D T2 maps with isotropic resolution that enable reformatting in any arbitrary cardiac view. Now the advantage is that the higher spatial resolution of the 3D T2 maps enable improved visualization of patchy inflammation, as can be seen here for a patient with sarcoidosis, where we can clearly see 3 patchy inflammations in the 3D case, which could have been missed in the 2D case due to the limited coverage and resolution. So in summary, I hope I was able to show you that PET-MR promises a comprehensive assessment of cardiac disease. However, although in most current cardiac protocols, PET-MR data acquisition is performed simultaneously, data is not necessarily co-registered, mainly due to the differences between 3D versus 2D acquisitions and the fact that some acquisitions are performed under free breathing and other ones under breath hold. So several approaches have been proposed to improve these and overcome these challenges, allowing motion correction for both the PET and the MR data. However, despite these promises, the impact of these new PET-MR methods on clinical routine and diagnosis remains to be investigated. So finally, I would like to thank our group at KCL and you for listening. Thank you very much.